Okay, thank you. Get going, please. The first thing I want to say is Debbie Milligan has had to resign from this post, and I wanted to thank her publicly and ask if Madeline can send a letter from all of us thanking her for all her contributions and her questions and her knowledge, but also her perception. And I think those things are important. So I think just to thank her very much for all she's done, because I think that's important. So if that's okay with her, thank you. Okay. We've got, I think, one apology from Matt. That's it. Yeah. Okay. Minutes of the previous meeting. Has anyone any comments on those? I thought they were very good. Very good. Very good. Very good. So I'll sign that at the end. Yes. Indeed. We have no public questions and no member questions. So we can get on to the business of the day. The first of all, the Royal Berkshire NHS Foundation Trust new hospital programme. Is that you, Andrew?
Yeah, that's me. Thank you, Chair. Obviously, colleagues would have seen the papers that we put together here. I'll move quite quickly, actually, through to the slide, page 8, that talks about the current position. So we, as previously reported here, we are subject to the new hospitals review. We are expecting that to report by the end of this month, possibly the week of the 20th. We have had no indication of what that might say, or indeed how conclusive it might be or specific at the point of which it's announced. I think we are, the review's been going on now for a number of months. We're very keen to get a definitive answer out of the review. That at least gives us direction and helps us give us a plan for that. In the meantime, we have been progressing some work. The majority of the rest of this pack here talks about some of the findings we've done, where we've looked at the kind of the consequences for residents and service users from different sites. We did that through a series of quantitative and qualitative bits of data. We had 10,000 people provide some views to us through a survey about their thoughts on the particular site. We got really good participation across all of our constituent areas, including from Wokingham, in that. And we also supplemented that with engagement of workshops with our staff, some community workshops, conversations with representative bodies as well. I think some of the really key messages of that is that from the sites that we've been looking at, none of them present any kind of insurmountable challenges, but none of them, each of them needs mitigation, and particular the challenges about access, and then access for people from deprived communities. Specifically, that access challenge is probably slightly higher for the university site, just because of the way in which public transport routes do currently run, and indeed actually the road networks in and around Reading run west-east is much easier than north-south, and that's what the kind of the picture says. It also suggests that that site changes the provides more change for where people might consider their closest hospital to be. I don't think that's particularly an issue for Wokingham residents, but for West Berkshire residents, the sites are both favourable. For East Berkshire residents, if you move to Thames Valley Park, you might make decisions to go to Wexham Park. A few people might make that decision. So I think this has been really useful in understanding the impacts for people, and it starts for us to think about, okay, what do we need to do with partners about providing access, and also what do we need to think about in terms of model of care, about what can we do with primary care networks to deliver more care at home. What might we want to leave in the centre of Reading to support deprived communities? So trying to understand more about the services that those communities particularly use is going to be a future piece of work for us. We also had some other findings about environmental risks, and again, which were not insurmountable, but really helpful to understand, and some of the economic impacts that we can foresee from the sites. The public survey results really focused in on access and people's challenges on access. A lot of that was driven about, actually, will I be able to park at the new site? Actually, more so than will I be able to access it by public transport or otherwise. But I think that the data analysis tells us that we should be really focused on the deprived communities and their access when we're looking at these other sites. There were some specific things pulled out by Wokingham residents and colleagues about the dynamics of this population and the significant rising in need of long-term conditions caused by the ageing and the growing health population here that we've been really put on our agenda from doing this work, which is really helpful. So yes, the next steps, we've got to await the outcome of the review. We've got to think about what that then means we've then got to progress the clinical model work, look at some of the travel and transport work, again with colleagues in the councils, and start to prepare all the business cases with colleagues in the council, and particularly with Matthew and the team in the ICB, who would lead on any consultation that is done in that space. We set up a series of regular meetings with Suzanne and her team, and Jonas, who's on the online today. So we're getting really good support and really good connectivity into the officials and their teams, which is really welcome. That's it.
There's any questions, but I mean, my first question is, what happens if it's the wrong answer?
I think it depends what we think is the wrong answer, and I think this is one that the outward message could be one of delay, some of which we are already aware of. So the original government promise was for 40 new hospitals to be delivered by 2030. Well, we already know that our planning assumption is that we would be being built from 2030 onwards. So that could be confirmed, but the outside message be seen as negative, but actually really positive. There could be further delay messages, but still a really firm promise to our citizens and residents that they will get their whole new hospital, and there could be other there could be other outcomes. I think that, you know, the one thing is really clear, that the infrastructure we currently have is not fit for purpose. So we will have to look at other sources of funding to keep the facilities that we're going to need for the future, which is not unlike other hospitals, particularly some in our ICB. But yes, it will not be the preferred outcome to not have a new hospital.
Thank you, Stephen.
It certainly wouldn't be the preferred outcome, but if the outcome were to be further delay, which is, I guess, eminently possible, do we know what the appetite of the two owners of the sites that we're talking about here, what their appetite is to accept that delay and continue to work with you, or is there a risk they'll pursue one or other of them, or both even, would pursue other options?
The sites are marketable. I think were we to get a firm commitment for a build on a given date, one of the things that we might go back with immediately is, okay, so you need to secure some of these great sites, and work with us about how you get some security on that. And that's something that we've been discussing as the next piece of work that we've got to progress, is get some security over what look like really good sites.
I guess I was thinking that was potentially somewhat less of a problem for the Thames Valley Business Park, where there's still quite a lot of vacant units and there is no real sign of a substantial uptake in use. But the University Science Park, I guess, they're starting to fill bits of it up, because they've got the British Museum, the Natural History Museum, Kew, all in the pipeline to arrive. And there may be a question about how long they will keep vacant the amount of land you require. That's what I was thinking of, more than the business park, which I think is less constrained in that sense.
I think I think we're concerned that both, concern is probably not the right word. I think given what we know about the sites, they're both really good, and I wouldn't want to lose both of them. So I think we would, if we were given a clear commitment about a whole new hospital, we'd want to work out how we can get some security.
Yeah.
Even if
I don't think we can carry this any further, really. I understand, it's not appropriate to take it any further.
I just wanted to reiterate, it has been really helpful to have the conversations with Andrew and CLT about how this is progressing. I think that just to raise a number of points that we've talked about, there are a number of matters that we've talked about. Jonas, as the Director of Public Health, is what our single point of contact, if you like, so we ensure that we've got a sort of clear sort of channel of communication about sort of matters. But in particular, we talked about accessibility. I know that that's something that's been mentioned. Also thinking about potential patients, but also people who will work at the hospital, and bus services to the hospital, thinking about that inclusive aspect. So that was something that we talked about at the last meeting. And secondly, something else that we talked about was the size of the hospital, bed space, and what that might mean in terms of what's needed in the community, knowing that there is going to be increased demand. So we can see that in the news in terms of the impact on hospitals right now, in terms of sort of winter pressures. So it's thinking forward, the size of a hospital locally, and then what do we need in the community to ensure that we're we can minimise the impact of sort of winter pressures like we're seeing.
Just as
Yeah, I mean the do nothing projection of how we currently organise our care says we'll need 25% more acute beds than we've currently got. But that means we'll also have 25% more people who are medically fit to not be in a hospital. So can we, I think we need to do something together about how do we get to a point where we're only building acute capacity for people who need acute care. But that does mean, how do we support people to live in how do we support people in community settings through the use of virtual hospital, through the use of primary care integrated teams, and anything else that people are thinking about. So it really pushes us into that debate. And also with Jonas, from a public health perspective, actually, what could we do to bend the curve that means that people are actually not living with the disease burden that they might otherwise be doing. Those are really massive agendas, almost actually more bigger than building a massive piece of infrastructure, and it needs all of us to be involved in it.
That's exactly where the Marmite agenda comes in for us, as a way of trying to reduce long-term demand by trying to engage much more in prevention, early intervention work on our side, which will help reduce the pressure on you. I think that's how we would see playing a role. But just to go back to those points about access and public transport, do those tend to point towards the business park as a better option, or are they relatively marginal in the assessment?
So as I said, neither site is insurmountable, but it poses us different questions. So because there's a kind of a bigger impact by moving to a different site, you might choose to leave more in the centre of Reading, and create a replica of some of our ambulatory facilities that we've got at West Berkshire, at Bracknell. And so the trade-off becomes: do you do that, and what's the kind of capital cost of doing that if it leaves you with a smaller hospital, versus building just one big centre? So that's the kind of that's what it tells us, is you're going to need to leave more. So how do we appraise the kind of the relative costs and benefits of that?
I can't see any more questions. I don't think so. So thank you very much, Andrew. And we might know, not next week, but the week after, something. But what, we don't know.
Correct.
So I think we'll all collectively keep our fingers crossed.
Yes, I think that's true. Okay, so we've got now the ICB joint forward plan. I presume that's you, Matthew.
So, thank you. I think, apologies, this is a bit of a process paper, but I felt, given the debate last time, it was useful just to outline the approach the ICB is taking to planning, both in terms of short-term and more of a medium-term strategy as we look to refresh the joint forward plan. So I'll just spend a little time updating on national context. We have just published our board papers, so probably in the last couple of hours. So there is a slightly updated planning paper, which I'll pick up some highlights from today, but you'll be able to read and link to that over the next few days. So I think I mentioned at I think Susan asked me last time about all the new money that was coming into the NHS. So I think our assessment is still that we are looking at a real term reduction in funding going into next year once all the pay awards are taken into account, and we've assessed the impact of national insurance changes. So we are facing a tough year, and again, just to remind board members that at the moment we are working towards a 60 million deficit as a system across Bob, but that is providing that in itself is quite challenging to deliver this year, but that's our target, and there will be a requirement to repay that deficit next year. So nationally, the planning context is challenged in terms of going into next year, and we're starting to see the guidance come out. In some ways, it's a constant frustration of the NHS, the timing of our planning guidance, and we normally get it as a bit of a standing joke. We normally get it on Christmas Eve, but we haven't managed that the last couple of years, so we're a bit behind that schedule. But seriously, in some ways, we know what we're going to deliver. We can predict the vast majority of what we're trying to do, both strategically and operationally, year on year. But it is useful because there's always a nuance in the detail once the guidance comes out. And if you look at the last few weeks, for example, you've seen quite a big debate around mental health investment standard and how that should be continue to be applied in the NHS. And also we've seen the National Elective Care Recovery Plan come out on Monday this week in terms of starting to give an indication of the level of ambition. And broadly speaking, that was as expected, that we continue to make progress towards those national constitutional targets and reduce waiting times. So the paper that you've had as part of your pack today outlines that we have started earlier than normal. So as a local system, we're trying to keep pulling our planning process slightly forward. We're still well behind local government planning timelines, but we brought it forward. So we've had some initial submissions. We've agreed principles across the system in terms of how we're going to plan. That we do intend to move towards break even. We do want to be more strategic in our commissioning at scale. We want to make sure we're using good evidence around that. We want to support the prevention agenda and that less shift. So we've got some good principles agreed. We've had a look at some of the numbers and the challenges, and they are large and scary in our first draft submission. We've got another set of submissions coming in at the end of January to work through. And the way we're trying to scope it is, we know we've got some short-term challenges, and so we are working with our trust and our NHS partners to say, what's the scale of the challenges? What would it take to get back towards break even? How can we push on productivity? But we're also doing a much more considered database piece of work with external support to really look at that population need, the demand forecast and the opportunities around that. Because I know that our fundamental challenge is that we've got real financial pressures today, but we've got a clear strategic intent around prevention and less shift. And it's how we balance those two is the business that we've got to work through over the next weeks and months. So we're not yet in a position to come back and sort of share the Bob summary, or indeed the local elements of some of that work. We're sharing it internally with partners. We've got DPHs involved in our weekly planning group, so we're starting to work through and validate that, and obviously as we develop our plans, we'll be able to bring that back into more public domain forums such as this one over the next weeks and months. So broadly the timeline, unfortunately it does look like we're likely to be submitting our plans for next year after the end of March again, which again is an unfortunate nuance of NHS planning. But I think we're more on the front foot. But go into some of the points that we were discussing around the new hospital programme. We've got to really find ways to accelerate some of the work around reducing discharges. We've got to find ways as a system to mitigate some of the demand growth that our acute trusts are seeing, because actually you'll see it in the numbers. The financial pressures are really evident in our acute trusts. I mean, the ICB has its fair share of financial pressures directly as well around CHC and mental health placements, but actually if you looked at the scope across Bob, where the financial pressure is being felt the hardest is our acute trust. So that's where we need to work to support the trusts in terms of demand management, maximising elective care to reduce costs there as well. So that's just a general update on where we are. I mean, we obviously would commit to bring an update to every health and wellbeing board in terms of how we're progressing and around that and aligning with local plans as well. So I'll probably stop there. Probably better for me to stop there and just take questions and comments really, as I can see a number of hands up already.
I've got through and then Stephen.
Thank you, David. I'm sorry to do this to you, Matthew. It's my perennial thing. That there's interesting things in the paper showing that you're talking to all the different trusts in the NHS. You've had workshops and so on to discuss stuff, and you're looking to do very sensible things. I mean, you've outlined some of your challenges, and I'm sure we feel your pain, but it would strike me that the people who know most about their populations and demographics are actually local authorities. So can you just sort of, there is reference to talking to local authorities, but not you. I don't know what engagement there has been, particularly with our public health team, in ways that could help you. And can you just explain what engagement you've already had with local authorities and what engagement you can have, so that we can try and produce produce this plan in the way that's least painful to you, as well as most helpful to us.
It might be useful to get Jonas's take on our engagement as well, and where we might need to improve it. But put simply, we have a weekly planning group. The DPHs are invited to, and they're engaged in the analytical work that we're trying to produce, because that has to be consistent and rely on some of the joint strategic needs assessment work. So I think we've reached out to make sure we've got that input into our core processes, but Jonas is more than welcome to support or challenge that statement. But certainly that's what the team have tried to put in place. Obviously, we are looking at an NHS planning cycle. There are aspects of how we plan together that we work directly with local authorities on, around BCF plans and the unified exec work. This internal group, though, is focused on NHS plans, but we've got the DPHs in our mechanism.
Do you want to say anything, Jonas?
Yeah, just on that. That's one of the meetings that we share amongst our BOB colleagues. So I think Matt Pearce and ANSAF feed into that particular meeting. But I know there's a workshop at the end of this month, which I'm sort of looking forward to. Certainly, I get all the notes from that meeting, and I find those very useful. I suppose it's just something about the analytics, I suppose, which is quite of interest to us in public health, about the development of that, and that's something we can pick up offline as well. But I would say that certainly we sort of work on a weekly basis with Helen Clark, certainly into the Berkshire West level, on those working in needs. So yeah, but again, I'm looking forward to that sort of workshop, Pathway to Sustainability workshop at the end of this month, which I think, Matt, you're going to.
Yes, and I'm glad, Jonas, you raised that, because actually that was one of my lines that I didn't highlight, was that workshop, a couple of workshops over the next few weeks to really get into that medium term stuff. Then hopefully, I think the challenge is sort of discussing with Andy and the team at the Trust, that I think we'll get some really good input from the analytics work and strategic challenges. The issue is, how do we quickly convert those into deliverable interventions into next year to try and balance some of that financial risk. So that's the real challenge. It's only 3 months to the 1st of April. We've got a huge financial challenge next year, and hopefully that sort of analytical piece will hold us to the ground on saying this is the strategically sensible interventions to be making, because it's going to be a tough round.
You got a comment now, Andrew, or can your question wait? Okay, we've got Stephen, then Susan, and then Alice, then Andrew.
Really, I was going to, I suppose, emphasise the point that flows out of what Prue said and what you've already said, Matthew, and Jonas has said. We do understand the financial pressure you're under, because we're under the same ourselves. We've lost £1 million of core revenue funding from the government, so it's not real terms loss, it's an actual loss of £1 million. So we do understand that, you know, this is posing great challenges, as you put it. But the answer, it seems to me, is as always, is to look outwards and engage more in partnership working and make those partnerships more fruitful, more meaningful, and perhaps to engage in with them at an early stage, and to recognise that what we do will impact on what you do, and vice versa. And I think we just need to try and ensure there's more integration of effort so that our preventative work feeds into your preventative work and so forth. So there is an opportunity here in the challenge to actually reinforce the partnership.
I'd agree with that. And I think, you know, I think we have the challenge. So obviously, there's different levels. We have the challenge at Bob level, but I think we also have that challenge to carry on with that integrated work at Unified Exec Berkshire West level, but also to think about how we really utilise, energise the local integration boards to really be in champion in the right areas to make some of that change. So I think there's a reliance on all of us, I think, to look through all those lenses to say how do we hold that integration and prevention piece through very difficult times. And I guess that is our challenge, isn't it?
It is a big challenge, and obviously the temptation when times are tough is to look inwards and to start thinking, how do we make these savings within our organisation, where I think the appropriate response is to say, this is the time, if more than ever, to look outwards and engage in those partnerships and make those partnerships fruitful and productive.
Susan. Okay. Alice. Alice.
Hi, thank you. Can you hear me? Can you hear me? Yeah, thank you. Thank you, Ben. One of the concerns I have with all this conversation is the public voice, because it's fine being top level conversation. So how much have you had the public involved in this? Because we are not part of this conversation as Health Watch.
And I think that's a fair challenge. I think the weekly process is still finding its feet in terms of so if I'm being honest, it's still very process focused. I think as is referenced in the paper, I think, and certainly in the board paper that's going to our public board tomorrow, next week, we will need to work through the engagement of the public and the formal consultation exercises that we may need to undertake. What I will do, though, Alice, is, because I don't know the answer to this, is take away an action around the workshop list and whether that has been extended to involve Health Watch membership. I'm not 100% sure, so I can take that away with Hannah as our lead director and say, at what point are we looking to engage Health Watch at that system level? Obviously, Health Watch are well engaged at various local bits of the architecture, but I take the challenge on the system level work, and I'll take that away as an action.
Thank you, Matthew. Susan.
Thank you. This was more of a general point as opposed to this particular year, but the analytics, I think, are crucial. And something which has been really helpful for us as a local authority was an index that was done by an independent organisation. It was called Empower, and it looked at productivity of all councils across England. And when it talks about productivity, it talks in terms of the outcomes that have been achieved, and plus the amount that's been spent. And I think it would be useful to know, take that approach with different aspects of spend that Bob spends in different parts of Bob. So to understand the productivity in, as I say, different areas of Bob. So I know it's not going to be done now, but I think it's a really good approach, because the analytics are really strong on this particular approach that Empower have taken, and it also benchmark. Not only does it look at all of the councils, but it benchmarks us against others in similar families, as it puts. So I think that I'm really keen that we get the analytics really, really sort of strong and meaningful. And also at the same time, it's the hidden inequality stuff. So we know that data tells us something, but in the same way that we were looking at Marmot, it's the what's beneath the average, what sits under the average. Whilst you might look at Wokingham and say, actually, there's lots of really good performance in Wokingham, but actually that beneath those averages are differences and inequalities. So it's granular and really understanding, and we can help with that because that's part of our Marmot approach. So those are sort of general points I wanted to make about data. And then the point about the savings, I know you've got, as you said, you've got the 60 million challenge. It's that whether you can buy yourself time with something. So we as a local authority talk in terms of there are some things that take a little longer to develop because you're going to put some more thinking into it, particularly when you're talking about prevention or new ideas and innovation. So it's not something you come up, I mean, I know you know this, you don't sort of like come up with it overnight. So it's how you can in some ways buy yourself some time to come up with the new sort of innovative stuff as well. And I don't know the ins and outs of the budget and how, but it's just whether that's something to consider as well, as in make one-off savings in some ways. Because this, I suppose, is the 60 million and you've got to continually make it, or is it a one-off?
No, the 60 million challenge will be a repayment challenge. So it'll be a repayment of this year's debt. So in some ways that will be a one-off challenge. So in strategic terms, if we can get back to break even next year, we would be in a marvelous position because effectively we would have overachieved against our recurrent run rate. But I think your point about time, I think, and it goes back to it's very difficult in the NHS. Always this part of the process says the plan has to be break even. This is the year it has to be break even. We know if you look strategically and take a step back, this system credibly needs to start to demonstrate a long-term plan to get back to break even. Now, the challenge today is that we do it next year. There are lots of debates as we understand the implications of doing that about whether we could develop a credible plan that would give us a bit more time. But at the moment, the messaging quite clearly nationally is next year is the year that the NHS has to come back on break even. So we are starting to work through that. But part of the debate is, do we fully understand what that would mean in terms of service provision? And do we need to articulate that in a way that says we need a bit more of a phased approach to that improvement? The point of data, I think, Susan. I think Andy may have a comment on the data. I know, Andy, you've probably been falling all over some of the data from your perspective, but I think we are trying to get quite granular on it, and there is some good benchmarking in there as well. So I think hopefully some of your observations will come out when we share the detail.
Yeah, I mean the data is really rich. I think you pointed out the real challenge next, though, and I think and you've started to chart the course, and I think like the more that we can chart the course, because we've got to go from identifying an opportunity to developing a solution, building on what citizens, patients telling us would work for them as well, and then getting on to deliver it in really quick time. So like working through the steps that organisations and places are going to need to go through to go from where we are, which is some really rich data being put together, to actually into delivery. I think is a really big challenge. And then thinking about where does this group sit in that path over the next 3, 6, 12 months would be really helpful.
That's a grave risk of sounding like a broken record. Just picking up on Susan's point about Empower's survey of local councils, the thing that those who were in the top 10 had in common was a commitment to partnership and partnership working. So it is well worth thinking about that, reflecting on that.
Absolutely, absolutely. I do get the challenge that it's tough, and if we retreat, we won't be successful. But it is tough. But yeah, I think absolutely, I'm committed to that.
Slightly different point. I mean, there are some things. First of all, I should say what neither Susan nor Stephen said is that we came out 5th in the country in that impact. So I think we should celebrate that fact. That can't be celebrated too often. But the point I wanted to make was about some of the challenges you've got, for example, hospital discharges and so on. And we do quite well here with that, with our Better Care Fund and all those things. And if you could get some of the other local government areas to perform in the same way that we do, that would help you as well, wouldn't it? So what is there we can do as a local government family to help you with those kind of issues where we do have a role to play? And I think that's something we can ask here, but it's something you can take away, because I think there are we're doing the best we can. I'm no doubt that other local authorities are trying, but they're not doing the same things as us, and they're not having the same outcomes. So if there are things where local authorities are not performing as well as each other, it would be good to be able to identify those, because there may be areas where we're not performing where we could learn from other local authorities. And so bringing that all into the mix is a way of producing the best result you can more consistently across your area.
Yeah, I think it's a really good point, isn't it? And I think in terms of how we organise ourselves, we quite rightly organise a lot of focus around our places, local authority boundaries, and we probably don't always do that good a job of comparing and contrasting. So undoubtedly, if you look at the discharge agenda, I'm quite certain that our analytics will show probably a multi-million-pound saving if we can improve our discharge management. And in terms of RBFT, for example, whilst there's some good practice in this system, there's still upwards of 100 beds that could be released if we can go further in terms of that space. So I think I will take that away, because I think if we think about our approach to discharge improvement as a system, I think the challenge that you highlight is, have we got our local authorities involved enough in that, talking to each other, challenging each other in terms of some of that work? Because my feel is, and sometimes it's difficult to engage local authorities in that system work, because actually there's not always that strong a motivation. So I think that's something that I'll take away, and perhaps I'll work with some local authority chiefs next about how do we get that system engagement of local authorities to do that healthy compare and contrast across our system.
I was really going to support what Prue said and what you just said. That I think that's a great point that Prue's made, and just turn it on its head and actually look at where as local authorities where we can do what, recognise absolutely there'll be more that we can do. So it's about learning from each other and taking that particular style of approach, as opposed to it's not actually beating people with a stick. It's actually, how do we learn from each other to improve this, and absolutely, as chief execs, we can help with bringing people together on this and learning.
Yeah, I think the NHS, and we obviously work together as Bob in the NHS. That's a formal structure, but even we struggle to do some of that best practice transfer. So I think there is room for improvement. We've got some really innovative models in different places that we can build on.
Okay, thank you very much. I think that's everyone. Yes, thank you very much indeed. Now it's the briefing paper. Is there anything really we've got to do? Do you want to say anything about it? I mean, sorry, the briefing paper.
Yeah, just a couple of points really. Firstly, I think we had a couple of debates last time I just wanted to update on because I wasn't sure they were quite captured in the minutes and actions, and I was conscious of them. So flu vaccinations, I think I had a challenge last time, probably from Prue, around local rates, and we've been struggling to get the breakdowns. But just to give you a flavour, we had on flu, we've had a 56.76% uptake in Wokingham. In terms of those eligible, that's against a Bob average of 57.3. So very close to the Bob average around that. In terms of vaccinations more generally, I think staff vaccinations have been a challenge this year in terms of numbers. So I think given the flu pressures across the system, we will need to do a bit of thinking around how we improve vaccination numbers going into next year. The other point that I think I did say I'd come back on was virtual wards, just to confirm that we don't have children's virtual wards in this part of the system. Oxfordshire is the only place that's got those up and running established at this point in time. So I just wanted to follow up those couple of particular queries. In terms of more general stuff, the change programme is we're now in the process where we're implementing it, so the structure's been agreed. We're now into recruitment and implementation. We sent around a note to system partners confirming, I believe, that Ben Riley's been appointed our CMO and will be the executive sponsor for Berkshire West as a system. Now, because that does cover 3 local authorities, that doesn't necessarily mean that Ben will be the Health and Wellbeing Board member across all 3 local authorities, but he will be the coordinating voice back through to the ICB board for Berkshire West. So we may have a mixed model of execs across the 3 local authorities. Once Ben comes in March, we will work that through and confirm that. But the Director of Place and Communities is in place. That's Dan Leveson, and he's reaching out to colleagues as part of his induction to start to work through that. So we're progressing on the change programme, and I'm glad to see the back of it, frankly, and it'd be great to recruit those vacancies we've got and move forward. I think I mentioned the Change NHS programme last time. And I think the rest of the update is principally for information. As I said, we've just published our board papers tomorrow, but outside of sort of planning and general performance updates, I don't think there's anything of particular note coming to the board for me to highlight today.
Thanks. Thank you. Thanks for that. That's helpful. In terms of the vaccination and on the point of data, what does the data tell us about who is and isn't taking up the vaccinations?
So I would have to take that away, Susan, because I had to work hard to get the percentage.
Oh, right, sorry.
I'd have to take that away because I had to work hard to get the percentage numbers for this session today. But I'm happy to take that away as an action. Perhaps ask Rachel Forster to drop a note round as to say what's the thematic issues that we've got from our vaccination challenges this year. It's not an area that I deal with on a daily basis.
Because again, it's local authority might be able to help in terms of communications, and it's something that I remember that we did during COVID. We looked at patterns of who was taking vaccinations.
Brilliant. So certainly I think it's terms of reflection and learning and going forward to next year, I'll ask Rachel to think about lessons learned or issues to address paper that we can take round to all partners.
Thank you.
Thank you.
An observation on the Change NHS 10-year plan. I put in a number of suggestions on the various portals of various things, and got acknowledgements and things, and they seem to be getting a lot of public engagement, and we'll wait and see how that goes. But it's one of those things where it could be exciting or it could be absolutely terrible. We don't know quite what's going to happen yet.
Let's remain optimistic. We've got one of our place directors, actually, Philippa Baker, has been seconded to the national team to work on that. So we've got a bit of a link in to that work as well.
Thank you very much. And then we've got the forward programme, and very little on the forward programme for March, in fact. Has anyone got anything they want to say or certainly if you do have ideas and so on, let Madeline or me or Matt Pope know, or Jonas. And I mean, so
I wonder if we can do something around mental health. I know it's very broad, so we may probably need to specify a little bit more about what we actually mean, but it's understanding a little bit more about waiting lists, provision for adults and for children, and also this, the different types of service that's offered and where and from whom, and just a bit more of. I wonder if that's of something that might be useful for the board, and having the Bob view and then the Wokingham sort of like view. I think would be good to debate that one.
Yeah, so happy to take that away for discussion. I think what we're keen to do, I think, is to think about how we probably better, more systematically work with health and wellbeing boards in terms of a Bob position. So we can do exactly that. We can say, actually, there is a standard mental health update that will go around to all health and wellbeing boards between March and June, and we'll do a local flavour as well as that Bob position. So again, happy to take that away and perhaps think about, it might be a session outside of this. Because I'm still fairly new to this. I'm not too sure how we develop forward plans outside of this discussion at health and wellbeing boards, but happy to think about that.
It would be useful for people to talk, I think, outside of this.
Yeah.
And so on.
Because one question I did have while I've got my mic on it is, in terms of sort of reporting against the health and wellbeing board strategy and implementation, is that something that comes systematically back through this board? Because I may have, I'm not sure I remember a report since I've been coming along, but I may have, there may have been one at the first meeting.
So we have, sorry, Debbie, we have meetings in between and we've got subgroups underneath, and they report back on the progress on those things. It might be good to articulate some of that in a public meeting.
Jonas.
Yes, I think Karen and I had a quick chat about this beforehand. So I think we've got an agenda setting sort of meeting coming up, maybe certainly with Madeline, but it's something about almost a thematic reporting schedule throughout the year, taking in mind the steering groups as well as this, as well as the board as well. And also we're thinking sort of carefully about how we best update people with regards to the Marmot work in terms of updates here, but also in terms of workshops as well. So I suppose watch this space at the moment, because that's quite an exciting place. And also we're thinking about how we link in with obviously the ICB around the Marmot work. So that might be something that we might want to talk about offline, if that's useful to yourself.
Thank you, Jonas. And certainly, having a year-round plan, but then there might be the occasional thing that comes up that we need to think of immediately. I mean, Alice has got something.
Yes, I mean, we've got a few projects that our report is coming out soon as well. So we've got the GP access, we've got the learning disability dentist experience, we've got the South Asian women's project, as well as young women's experience with sexual health services as well. So there are a few that we can share as well.
Thank you, Alice. Okay, so having had very little, we've now got an awful lot. But yeah, I'm sure it'll be spread out and so on, and be appropriate. But certainly that's been a positive time. Okay, if there's no more questions or comments, I think that's it. So thank you all very much for coming, and hopefully I'll see you next time. And hopefully by